And this case actually also, these are the chromosomal abnormalities. As you can see, numerous chromosomal abnormalities typical for solid tumors, but definitely doesn't have ERB-B2 amplifications here. And next slide. Now, what's very interesting about this patient is the overexpression of Interleukin-2. So clearly our software classify her as breast cancer, but the overexpression of Interleukin-2 give us a hint that there is something else wrong with the Interleukin-2. Next slide. And when we look at fusions, definitely the patient has Interleukin-2 fusions as well as other fusion involving FGFR1. Patient has very high TMB, and these are hair mutations. So this is one of the rare cases of Interleukin-2 fusion and overexpression. I should say that almost always, whenever you have overexpression of Interleukin-2 or any of the genes that are related to fusions and translocations, if you see overexpression of RNA, you got to look for the fusion or the translocation. So this patient, clearly one of these examples, but yeah, the opposite is not necessarily true. So we have a lot of patients who have overexpression of Interleukin-2 without fusion. And all these cases raise the question whether we will be or should be looking or treating patients based on the expression rather than the fusion, because most of the time the outcome is, the biological outcome is almost the same. Next slide, please. And this case actually didn't really have any mutations in the peripheral blood when we did the peripheral blood on this patient. And this is actually to show you that the mutation in the tissue detected in the DNA and the RNA in the first and second panel. But if you look at the third panel, you see some mutation, but they are not relevant. They are not clonal, and they are not the same mutation we detected in the biopsy. So these are artifacts, and they are not clonal abnormality. So this is one of the examples where there is no, there's very low tumor burden, and we didn't really detect any mutation in the cell-free DNA in this particular patient. Next slide. And this is the summary, and in particular, the presence of the Interleukin and the FGFR fusions, and the high TMB and BDL1 expression as well. So, Dr. Weintraub?
This is most interesting because this is a woman who's 45 years old with triple negative, locally advanced breast cancer, who got adriamycin, Cytoxan, and then Taxol carboplatin to shrink her tumor. She had significant residual disease and underwent her mastectomy. And I decided to do next-gen sequencing on her blood and on her tissue of the residual disease to see what would be the best thing to give her to prevent her cancer from coming back. I didn't expect her liquid biopsy to be positive because her tumor burden is very low right now because she's had surgery and her PET scan's negative. Her GTC solid was extremely important because her TMB is high and she overexpresses SP142, telling me that she should have significant response to immunotherapy. So she's getting 6 cycles of, quote, adjuvant immunotherapy now with Keytruda because of the TMB that the GTC lab of Dr. Albertar picked up.